If you're afraid to talk to people because of bad breath, listen. That feeling of holding back your voice, leaning away from conversation, or rehearsing excuses to avoid close talk is more common than you think. And most of the time, there is a clear, manageable path forward. This is not about blame. It's about practical steps you can take in the next 48 hours to find the likely source and decide whether a simple self-care run will do it or whether you should see a clinician. First, a quick reality check. Bad breath, or halitosis, usually comes from places you can't reach with a toothbrush alone. The mouth is an ecosystem. Teeth, gums, tongue, tonsils, saliva, and the back of the throat all host bacteria. Some of those bacteria produce volatile sulfur compounds, VSCs, which smell like rotten eggs or garlic. Other molecules can smell fruity or like acetone. Those scent patterns are clues, not a final answer. Sulfurous odors often point to bacterial breakdown in the mouth, tongue coating, gum pockets, or trapped food around restorations. Fruity or sweet smells can suggest metabolic changes, but that's less common and usually something a primary clinician would evaluate. Before you spend money on expensive rinses or avoid social life, try 3 fast, non-shaming checks that take about a minute or 2 total. These 3 simple tests narrow the likely sources and point you at the right next step. First check, the tongue scrape. Stick out your tongue and look at the back. A thin white or yellow coating, especially toward the rear, often indicates a tongue coating that can hold odor-producing bacteria. Using a clean tongue scraper or a spoon, gently scrape from the back of the tongue forward a few times and smell the scraper. If that scraping smells distinctly sulfurous, the tongue is a likely contributor. Do this test once, then rinse and repeat the scraping in the next days as part of your trial. How to do it safely? Use a soft, purpose-made scraper or the back of a spoon. Don't force a deep, uncomfortable scrape. You're collecting surface coating, not digging into tissue. If you have an active gag reflex, move slowly and breathe through your nose to minimize discomfort. Second check, the gauze or floss smell test. Take a clean piece of dental floss, preferably waxed if your teeth contact tightly, or a 2x2 piece of sterile gauze. Gently floss one area where food often gets stuck, for many people, the back teeth, or rub the gauze along the gum line. Immediately smell the floss or gauze. If there's a foul, persistent odor on the floss or gauze, that suggests a periodontal pocket or trapped debris around a restoration could be a contributor. Again, this is a screening test. It suggests you should see a dentist for probing and a professional assessment of pockets or failing fillings. Perform floss gently. Don't force floss into a tight space with pressure that causes bleeding.
Some bleeding may happen if gum disease is present. That itself is an important clue, but don't use bleeding as your only measure of severity. Note it and bring it up to your clinician. Third check, the visual tonsil check. Using a flashlight and a mirror, open wide and look at the tonsils at the back of your throat. Tonsil crypts are normal, and small white or yellow deposits, tonsil stones or caseous material, can accumulate. If you can see obvious stones or persistent white debris lodged in the crevices, tonsil tissue may be trapping bacteria and food particles that release odor. If you can't see anything but still suspect tonsil-related odor, that doesn't rule it in or out. Some stones form deep in crevices where they're not visible. Important safety note, do not attempt forceful removal of tonsil stones with sharp objects. Gentle rinsing and conservative methods are appropriate to try first. More invasive removal should only be done in a clinic setting. If stones are large, painful, or recurrent, that's an ENT referral situation. After you perform these 3 checks, write down what you found. That short note, tongue scraper smell, yes, no, floss gauze smell, yes, no, visual tonsil stones, yes, no, will guide the next steps. If one of those tests lights up, the solution path becomes much clearer. Type 1 in the comments if one of the tests matched what you found, and subscribe so you can watch the hands-on demo where we show exactly how to perform each one safely. Now here's a clinician-tested, time-limited plan to try next, a targeted 48-hour diagnostic trial. Think of it as an evidence-based experiment, small, specific, and measurable, designed to reduce the most common, treatable sources of oral odor. The goal is not to promise an instant cure. It's to collect information, Does careful, focused oral hygiene over 2 days meaningfully reduce the smell? If yes, the likely culprit is something that responds quickly, often tongue coating. If not, and your checks pointed elsewhere, you'll use that information to choose a dentist, ENT, or primary care visit. What to do in the 48-hour trial? Follow a simple morning and evening routine and a few actions after meals. Day 1 starts when you wake. Morning routine. First thing after waking, without eating, use a tongue scraper. Gently scrape the back of the tongue forward 2 to 3 times, rinse the scraper, and repeat as needed. Use light pressure. Brush your teeth and the front surfaces with a routine you already know. Use a soft brush. Focus on thorough cleaning, but avoid aggressive scrubbing that causes gum irritation. Floss or interdental clean to remove trapped food and biofilm. If you have tight contacts and floss causes pain, switch to interdental brushes of an appropriate size or a water flosser if you have one and it's comfortable. Rinse with a single, short course of alcohol-free antibacterial mouthwash once daily, preferably after brushing, strictly for the 48-hour trial.
The purpose is a time-limited reduction of bacterial load, not long-term suppression. Avoid chlorhexidine and other prescription-strength antiseptics unless prescribed. Those should be used under clinician supervision and not for prolonged periods because of side effects like staining and taste disturbance. Perform a warm saltwater gargle, about half a teaspoon of salt in an 8-ounce cup of warm water. Gargle for 15 to 20 seconds and spit. This helps loosen debris in the back of the throat and can be soothing. Do this twice daily, morning and evening. Hydrate. Drink water throughout the morning. Dry mouth worsens odor because saliva washes away bacteria and volatile compounds. Aim for consistent sipping, not gulping as a one-off. After-meal mini routine. If you can, choose xylitol gum after meals for about 5 minutes. Xylitol helps reduce certain bacteria's ability to stick and reproduce. If you don't tolerate gum, rinse your mouth with water or swish briefly to remove debris. If you've eaten strong-smelling foods, garlic, onions, use the tongue scraper again and rinse. Evening routine. Repeat the morning brushing, flossing, interdental cleaning, tongue scraping, and warm saltwater gargle. If you used an alcohol-free mouthwash in the morning, avoid doubling up with multiple antiseptic rinses in a day. Keep to a single, once-daily use during the short trial unless otherwise directed. Keep a bedside glass of water to sip if you wake during the night. Minimizing prolonged dry mouth can help. Documentation. Keep a simple log. Each entry should be one line. Date, morning breath score, 1 to 10, 1 minimal, 10 very strong. Evening breath score, 1 to 10. Any odd foods or medications, and which of the 3 checks were positive earlier. Do this for 2 days. Photograph the tongue scraping result on your phone if you're comfortable. The visual record can be helpful when you discuss next steps with a clinician. What to expect after 48 hours. If tongue coating was the main contributor, it's common to see a meaningful reduction in odor within 48 hours if the scraping is done correctly and consistently. You may notice a cleaner taste and lower morning breath scores. If the floss gauze test was positive and you have periodontal disease, you may see some improvement in odor, but persistent smell often requires professional cleaning and pocket management. That typically takes longer than 2 days and may need a dentist or periodontist. If tonsil stones were visible and you rinsed, gargled, but still smell persists, ENT evaluation may be appropriate, especially if stones recur or are large. As you undertake this trial, keep an eye out for red flags that require earlier attention. Significant mouth pain, fever, difficulty breathing, uncontrolled bleeding, swollen neck or face, or marked changes in voice or swallowing. Those are signs to seek urgent medical evaluation. This 48-hour trial also has reasonable limits. Don't use strong antiseptic mouthwashes repeatedly for more than a day or 2 without clinician input. Don't start or stop prescription medications on your own. If you use inhalers, certain antihistamines, antidepressants, or other medications that cause dry mouth, note them in your log and bring them to your clinician's attention. The medication may contribute to a dry oral environment and persistent odor. Let's walk through how these steps look in practice with a few short examples you can relate to.
Anna is a mid-30s teacher who avoided small talk with colleagues. She'd brush faithfully twice a day, but still felt self-conscious. During her first check, she found a noticeable coating on the back of her tongue, and the scraper smelt distinctly sulfurous. She followed the 48-hour trial: gentle tongue scraping morning and night, salt gargles, once daily alcohol-free rinse, and xylitol gum after lunch. She logged morning breath at a 7 out of 10 on day 1 and a 3 out of 10 after 2 days. That pattern suggested tongue coating was the prime contributor. Her relief was practical. She kept the scraping habit and scheduled a routine dental hygiene visit to rule out other contributing factors. Marcus is in his 50s and had noticed his partner mentioning persistent gum bleeding. His gauze floss smell test produced a foul odor, and he had routine bleeding on brushing. He did the 48-hour trial but saw only modest change in odor. Because his checks suggested periodontal involvement, the likely path was a dentist or periodontist appointment for probing, cleaning below the gum line, and a tailored plan. In Marcus's case, improvements take weeks to months rather than days. The 2-day experiment didn't rule out professional disease. It helped prioritize the proper referral. Leah's history included seasonal allergies and frequent postnasal drip. Her tongue scraper and floss tests did not show strong results, and her tonsils looked unremarkable. The odor she described was intermittent and often accompanied by a sensation of mucus in the throat. For someone like Leah, an ENT evaluation for chronic postnasal drip or sinus issues is reasonable, alongside hydration and saline nasal irrigation trials if she's comfortable with that technique. Documenting the timing, when the odor is worse, morning, after lying down, after certain foods, helps the EMT focus testing and treatment. Those 3 vignettes illustrate the triage mindset: quick self-tests, a short, consistent trial, and then targeted escalation if necessary. The next step is to understand why each reservoir behaves the way it does, because that explains why some fixes work quickly and others need professional input. The tongue is a major reservoir. Its rough surface, the papillae, traps desquamated cells, food debris, and bacteria. When those bacteria metabolize proteins and other substrates, they release VSCs. That's why tongue scraping often gives the quickest relief. You remove the physical reservoir.
Not everyone needs aggressive or abrasive cleaning. Gentle, consistent scraping reduces the biofilm that produces odor. If your tongue scrape test was positive and you saw improvement during the 48-hour trial, a long-term habit of daily scraping, done gently, often keeps the issue controlled. However, if the coating is extreme, persistent despite good hygiene, or accompanied by other symptoms like severe dry mouth or unusual oral lesions, a dental evaluation is warranted. Periodontal pockets are a different story. When the junction between tooth and gum breaks down, bacteria colonize below the gum line in pockets that toothbrush bristles and superficial rinses can't reach. These environments are low in oxygen and favor bacteria that produce malodorous compounds. The floss or gauze smell test points to this possibility, and bleeding gums, gum recession, or loose teeth are clinical signs you shouldn't ignore. Professional scaling and root planing, improved home care guided by a hygienist, and monitoring are typical next steps. Expect weeks, not days, for the smell to improve after professional therapy, because pocket healing and reduction in subgingival colonies takes time. Restorations, old crowns, bridges, poorly fitting fillings, or food traps around implants or orthodontic appliances can also harbor bacteria. If your floss test smells and you notice a specific area where food lodges regularly, that's a clue for a dental assessment of restorations. Sometimes simply replacing a defective filling removes the niche for bacteria. Sometimes the solution is more involved. Again, the 48-hour trial is a diagnostic probe. If nothing shifts after focused hygiene and the floss test stayed positive, restorations are a likely suspect and a dentist's exam is next. Tonsil stones form when material collects in the pits of the tonsils and calcifies. For some people, these stones are a transient nuisance. For others, they recur frequently and cause persistent odor. Conservative measures include regular saltwater gargles and good oral hygiene. Some people find gentle, supervised rinsing with a bulb syringe at home under ENT instruction can dislodge small stones.
Others may need ENT assessment for options ranging from in-office removal to tonsillectomy in rare refractory cases. For now, the rule is clear. Avoid sharp or forceful attempts to dig stones out yourself. That increases the risk of bleeding and infection. We've already touched on ENT causes like chronic sinusitis and postnasal drip. Those conditions bring mucus and bacterial load from the nasal passages into the throat, and the resulting smell can be intermittent and tied to body position or allergy seasons. Saline nasal irrigation may help as an initial non-pharmacologic step if you suspect postnasal drip. Again, document changes and bring your notes to an ENT if improvement is limited. Systemic causes are less common but important to recognize because they may require primary care evaluation.
Fruity, acetone-like breath can be ketosis from fasting or metabolic changes. A strong ammonia smell may suggest renal issues. A musty or sweet odor could point to liver disease in certain contexts. If your self-checks are negative and the smell is more generalized or accompanied by symptoms like unexplained fatigue, swelling, or changes in urination, make an appointment with your primary clinician. Throughout this process, documenting changes helps you and clinicians make better decisions. A simple log entry, date, morning breath score, evening breath score, what you ate, what medications you took, whether you did tongue scraping, flossing, rinses, and any visible findings creates a timeline. When a clinician asks, when did it start, what makes it better or worse, you'll have an accurate record rather than a fuzzy memory. Safety and realistic expectations are central. Avoid the temptation to overuse antiseptics. Antiseptic mouthwashes have a role in short-term trials and certain clinical indications, but some are not intended for indefinite daily use because they can alter taste, stain teeth, or disrupt the oral microbiome in undesirable ways. If you're considering prescription mouthwashes or topical agents, ask a dentist. If you have an autoimmune condition or take medications that cause dry mouth, discuss those with your primary clinician rather than altering prescriptions on your own. At this point, you've done the 3 checks, logged findings, and started the 48-hour trial. Give the trial your best consistent effort, morning and night routines plus after-meal measures. If you notice substantial improvement in your breath scores within 48 hours, especially if your tongue scrape was positive, then maintain the gentle scraping habit and schedule a routine dental hygiene visit to make sure nothing else is contributing. If you see minimal or no change and your floss test was positive, prioritize a dental appointment. If the tonsils or sinus symptoms are the main clue, arrange an ENT visit. If your checks are negative across the board, yet the odor persists or has unusual qualities, fruity, ammonia, or systemic symptoms, call your primary care clinician to investigate metabolic, renal, or hepatic causes. As you prepare for any clinical visit, a short script can help you communicate efficiently. Describe the onset, list the 3 checks results, summarize the 48-hour trial and the change in breath scores, note medications and recent dietary changes, and mention any red flags like pain, fever, or difficulty swallowing. Bring your log and any photos you took of tongue coating or visible tonsil material. Clinicians appreciate concise, documented information. It shortens the path to the right test and the right specialist. Before we go deeper into each cause and what the longer-term timelines look like, there are a few more practical, safety-minded details about the trial and about behaviors to avoid.
Don't use fingernails, toothpicks, or sharp instruments to try to dislodge debris from tonsils or deep gum pockets. Don't alternate multiple types of potent antiseptics at home in hopes of a quick fix. If you use a water flosser, start at a low pressure setting to avoid damaging gums. And if you have a bleeding disorder or are on blood thinners, inform your clinician before choosing at-home devices. One more practical tip. The social anxiety piece is real and valid. If you're nervous about being in close conversation, small behavioral adjustments while you resolve the cause can help. Sip water during long conversations. Take a brief step back before speaking if you need to reset your breath parameters. And, when appropriate, be honest in low-stakes situations. I'm working on a persistent tooth/tongue issue. Please let me know if my breath seems off. Most people appreciate candor and will respond kindly. We're now at a decision point. After your initial 48-hour experiment and the documentation you've made, either you'll see clear improvement, suggesting a fast-responding source like tongue coating, or you'll have enough clues to choose the right clinician. Dentist/periodontist for floss or gauze-positive results, ENT for visible or recurrent tonsil stones and sinus/postnasal drip symptoms, or PCP if the smell has systemic features or if you need medication review. In the next section, we'll examine each reservoir in more detail, what to expect over 2 weeks, what clinicians will look for, and the scripts you can use in a dental, ENT, or primary care appointment so you're fully prepared for the next step. If you've done the 3 checks and run the 48-hour experiment, the next practical step is to translate those immediate clues into realistic expectations and a plan for the coming 2 weeks. That's the window where some problems either settle with consistent care or they reveal themselves as issues requiring professional management. Below, I'll walk through each major reservoir and what to expect, how clinicians approach them, what to document, and how to communicate efficiently when you book an appointment. Tongue coating, what to expect and why it often responds quickly. The surface of the tongue is rough. Millions of tiny projections trap cells, food particles, and microbes. Those microbes metabolize proteins and produce volatile sulfur compounds, VSCs, and other smelly molecules. If your tongue scrape smelled sulfurous during the home check and your 48-hour log showed a meaningful drop in morning breath scores, the tongue was likely a major contributor. What continued home care should look like over 2 weeks? Gentle daily scraping, morning and evening, after brushing. Use light pressure. The objective is removal of the surface biofilm, not aggressive abrasion of tissue. Maintain consistent flossing, interdental cleaning, and hydration. Reduced debris and more saliva both help.
Keep a simple log entry each day. Morning breath score, evening score, any visible coating photos if comfortable, and notes on foods or medications that seem to affect odor. Expect to see steady, incremental improvement over 2 to 14 days. Many people notice the first big shift in 48 to 72 hours when scraping is done correctly, and then smaller gains as the habit becomes established. When to see a dentist after a tongue-related improvement? If you improved but the coating recurs frequently despite consistent scraping. If you have severe dry mouth, unexplained oral lesions, or pain. If scraping provokes significant gagging or blood, discuss technique with a dental hygienist. Periodontal pockets, why the timeline is longer. Periodontal disease creates pockets below the gum line where oxygen is low and anaerobic bacteria thrive. These bacteria are often high producers of malodorous compounds. The gauze floss smell test is a useful home screen but cannot quantify pocket depth or bone loss. What the next 2 weeks tend to show. Short-term hygiene, the 48-hour trial, may slightly reduce surface odor but will not resolve subgingival reservoirs. After professional cleaning, scaling, and root planing, it may take weeks to months for pocket depths to shrink and microbial populations to rebalance. Home hygiene afterwards, guided by a hygienist, speeds recovery. If you noticed bleeding gums, persistent bad taste, or loose teeth alongside a positive floss smell test, prioritize a dental appointment sooner than later. What the dentist will do and what to bring. Probing depths, periodontal charting, and radiographs to evaluate bone levels. Professional cleaning, possibly more intensive root planing under local anesthesia if pockets are deep. A tailored home care plan, specific interdental brush sizes, flossing technique, and frequency. Bring your log, dates, scores, floss gauze results, and any photos. That concise documentation helps them triage and plan efficiently. Restorations and appliances, clues and likely fixes. Ill-fitting crowns, broken restorations, food impaction around bridges, poorly contoured implants, or ill-fitting dentures create niches where food and bacteria accumulate. A floss gauze test that smells foul and a pattern of food trapping at a specific tooth strongly suggests this cause. What to expect over 2 weeks. Home hygiene may reduce surface odor slightly, but mechanical niches persist until fixed.
If the restoration is indeed the problem, clinical evaluation and targeted dental work, repair, replacement, or recontouring usually resolves the niche and leads to odor improvement after treatment and a short healing period. What to bring to the dental visit? A description of the tooth or area that traps food, photos if possible, and your log. The dentist will assess margins, contacts, and may take radiographs.
Tonsil stones, conservative care, caution, and referral thresholds. Tonsil crypts can trap debris that calcifies into stones. Visible small white deposits often suggest tonsil involvement, and when they're present, the odor can be very sulfurous. Conservative measures to try for 2 weeks. Warm saltwater gargles twice daily and after meals. This helps dislodge loose debris and create a less favorable environment for bacteria. Maintain tongue scraping and oral hygiene. Reducing oral bacterial load decreases the material available to form stones. If you choose gentle irrigation, use a bulb syringe with lukewarm saline at low pressure and only after discussing technique with the clinician, or if you've seen a trusted demonstration. Never use sharp or pointed objects to dig at tonsils. Document recurrence, size, and whether stones are painful or associated with bleeding. When an NT referral is warranted. Recurrent, large, symptomatic stones despite conservative care. Stones associated with persistent sore throat, ongoing ear pain, or difficulty swallowing. If in-office removal is needed, NT can perform it safely. Rarely, persistent, disabling tonsillitis with recurrent stones leads to discussions about more definitive options. NT and sinus causes. How postnasal drip creates intermittent odor. Chronic sinusitis and postnasal drip bring mucus and bacteria from the nasal passages into the back of the throat. The odor may be intermittent and tied to posture, rhinitis flares, or allergy seasons. If your 3 home checks were largely negative and your symptom pattern includes throat mucus, throat clearing, or frequent coughing, NT evaluation is reasonable. NT diagnostic steps and what you can expect. A focused history and nasal examination, often including nasal endoscopy to look for chronic inflammation, polyps, or purulent discharge. Imaging, CT of the sinuses, may be used when structural or chronic disease is suspected. Treatment options are varied: saline irrigations, topical steroid sprays, allergy management, antibiotics for confirmed infection, or sinus procedures in refractory cases. Document when odor is worse, after lying down, morning, after certain exposures, and any allergy history to help guide testing. Systemic causes, when the breath isn't just an oral problem. Less commonly, systemic conditions create characteristic breath odors. Fruity or acetone-like breath can reflect ketosis from fasting or uncontrolled diabetes in some contexts. Ammonia-like breath can suggest renal issues. Musty or sweet odors might relate to liver disease. Medication side effects and conditions that reduce saliva production, xerostomia, can also increase odor risk. What to do if you suspect a systemic cause? If your 3 checks are negative and the odor has unusual qualities, or you have systemic symptoms, unexplained fatigue, swelling, altered urination, weight loss, make an appointment with your primary care clinician.
Bring your log, note the smell characteristics, fruity, ammonia, musty, list all medications, supplements, and recent changes in diet or fasting behavior, and mention other symptoms. Medication-related dry mouth. Many common medications cause dry mouth: antihistamines, some antidepressants, anticholinergics, certain blood pressure drugs, and others. If you're on medications that might cause xerostomia, document them and discuss possible alternatives or supportive measures with your prescriber rather than stopping the medication yourself. 2-week structured follow-up plan: how to log and what to expect. If the 48-hour trial produced partial or temporary improvement, extend a structured routine for 2 weeks to gather clearer data. This helps distinguish fast responders from problems requiring professional care. Follow this plan. Daily routine: morning, tongue scraping, brush, interdental cleaning, warm salt gargle, hydration. After meals, xylitol gum for about 5 minutes or a water rinse. Evening, brush, interdental clean, tongue scraping, warm salt gargle. One daily use of an alcohol-free mouthwash is allowed as part of a time-limited trial, but avoid consecutive antiseptic products daily unless directed by a clinician. Logging. Each day, list date, morning breath score, 1 to 10, evening breath score, 1 to 10, positive checks that day, tongue, floss, gauze, tonsil observation, foods of concern, medications taken, and any relevant symptoms, dry mouth, sore throat, bleeding gums. Optional, a photo of the tongue coating or visible tonsil deposits on a few days to show trends. What improvement looks like. Tongue-related odor. Meaningful reduction in scores within 48 to 72 hours, continued improvement over 2 weeks with maintenance. Periodontal disease. Modest change in 2 weeks, larger improvements expected weeks to months post-professional therapy. Restorations. Persistent smell until mechanical issues are corrected. Tonsil stones. Variable. Some people improve with gargles and hygiene, others need ENT care. Sample log entries, showing realistic patterns. Anna. Day 1, AM 7, PM 5. Tongue scrape positive, used salt gargle. Day 2, AM 3, PM 2, tongue scrape less coated. Photo shows reduced coating. Conclusion, tongue dominant, continue daily scraping. Marcus. Day 1, AM 8, PM 7, floss gauze positive, bleeding noted. Day 14, AM 6, PM 5, slight improvement with improved home care, but persistent foul odor. Conclusion, likely periodontal pockets, dental appointment recommended. Leah. Day 1, AM 6, PM 4, checks mostly negative, symptoms include postnasal drip and intermittent bad taste. Day 14, little change and mucus persists, ENT referral advised. How clinicians will triage based on your notes. A concise, documented patient history halves the evaluation time. When you schedule an appointment, tell the clinic, I did a short home trial for bad breath and logged results. I'd like an evaluation.
At the appointment, present a 1-page summary. Onset, 3 checks, yes, no, 48-hour trial results, 2-week trend, medications, and red flags. This helps the clinician decide whether to do simple chairside tests or refer for deeper diagnostics. Patient scripts for appointments. What to say to be concise and useful. Dentist/periodontist script. Hello, I've been worried about persistent bad breath. I did the 3 home checks. My tongue scrape was positive/negative, floss/gauze was positive/negative, and I saw no, yes tonsil debris. I kept a 2-week log with morning/evening scores and photos. I noticed bleeding with brushing and food trapping at the upper left molar. I used a 48-hour focused routine with tongue scraping, flossing, and salt gargles, and the odor partially improved/not improved. My main concern is whether I have periodontal pockets or a failing restoration causing this. Can you assess pocket depths and the restorations and advise treatment options? ENT script. I've had intermittent bad breath and frequent throat mucus. My home checks were negative for tongue coating and floss smell, but I often clear my throat and feel mucus at the back of the throat. I did a 2-week trial with saline irrigations and logged symptoms. The smell is intermittent and seems worse when I lie down. Could we evaluate for chronic sinusitis or postnasal drip and discuss testing and treatment? Primary care script. My breath has a fruity, ammonia, musty quality, and my home checks for oral sources were negative. I kept a 2-week log and noticed other symptoms: fatigue, changes in urination, weight loss. I'm concerned about systemic causes. Could we review my medications and consider basic metabolic testing? Clinician checklist you can offer or expect in a visit. To speed evaluation, clinicians often follow a short checklist: oral exam, tongue, teeth, gums, tonsils, periodontal probing, restoration assessment, oral cancer screening, dry mouth assessment, and systemic review, medications, systemic symptoms. ENT adds nasal, sinus exam, and endoscopy if indicated. PCP focuses on medication review and targeted lab testing. Tonsil stones.
Practical conservative techniques and what to avoid. Conservative care that is safe to try. Warm saline gargles twice daily and after meals. Daily tongue scraping and good oral hygiene. Hydration and saliva stimulation, xylitol gum if tolerated. Cautions and what not to do. Do not use sharp objects, toothpicks, or forceful fingernail digging into tonsil crypts. These actions risk bleeding, infection, and scarring. Avoid prolonged use of high-strength antiseptics without clinician supervision. If you feel the need for repeated antiseptic rinses beyond a short trial, discuss this with a clinician. Bulb syringe irrigation can be used gently at low pressure, but only with appropriate technique and instruction. Stop if it causes pain or bleeding.
When ENT might offer procedural options. In-office removal under direct visualization for larger stones. Laser or coblation of crypts as a less invasive option in specialized centers. Tonsillectomy is rarely needed, reserved for severe, recurrent, symptomatic cases after conservative measures fail. Red flags that require urgent care. Some signs suggest more than routine halitosis and need prompt or emergency evaluation. Sudden severe facial swelling, difficulty breathing or swallowing. High fever with severe mouth or throat pain. Rapidly expanding neck swelling, especially with pain or redness. Persistent, unexplained oral bleeding or large boils or abscesses in the mouth. Marked systemic symptoms, severe fatigue, confusion, decreased urine output, along with new, strong, abnormal breath odors. If any of these occur, seek immediate care at an urgent care facility or emergency department and tell clinicians you have oral/throat symptoms with systemic signs. Behavioral tips that support clinical care and reduce social anxiety. While you're in the diagnostic window and waiting for clinician appointments, practical non-shaming strategies help maintain social engagement. Keep a small bottle of water with you and sip periodically during conversations. Chew sugar-free xylitol gum for a few minutes after meals if tolerated. Use discreet breath mints that are sugar-free as a temporary social buffer, not as your only strategy. If you feel comfortable, frame it briefly. I'm managing a mouth issue right now. Let me know if my breath is off. In many contexts, people will respond supportively. Practice good sleep hygiene and hydration. Mouth breathing at night often worsens morning breath, so addressing nasal congestion or use of a humidifier can help. Maintenance strategies after resolution or professional therapy. Once the acute source is identified and managed, long-term maintenance focuses on reducing risk of recurrence. Daily tongue scraping. Twice daily brushing, daily interdental cleaning, and regular professional hygiene visits as advised. Address xerostomia. Sip water, chew sugar-free gum, consider saliva substitutes if recommended by your clinician. Review medications periodically with your PCP for agents that may cause dry mouth. Treat chronic rhinitis or sinus disease proactively with ENT guidance. What to expect from different specialists briefly. Dentist/periodontist, probing, scaling and root planning, restorative correction, and a hygiene schedule. Expect follow-ups over weeks to months for periodontal recovery. ENT, nasal endoscopy, possible imaging for chronic sinus disease, in-office tonsil management, or discussion of procedural options for recurrent tonsil stones or crypt-related disease. Primary care, medication review, basic metabolic labs, and referral to nephrology, hepatology, or endocrinology if systemic causes such as renal failure, liver disease, or uncontrolled diabetes are suspected.
How to present your findings if you decide to bring documentation. A one-page summary is ideal. Brief timeline, when it started, 3-check results, yes or no, 48-hour trial summary, 2-week trend with morning-evening scores, photos if taken, medication list, and red flags. That compact format lets clinicians prioritize testing and management quickly. Closing the loop, decision pathway, and realistic next steps. After 2 weeks of structured documentation and targeted care, your decision path should look like this. Substantial improvement. Maintain home regimen, schedule a routine dental check, and monitor. partial improvement with positive floss gauze test, schedule dentistry for periodontal assessment and restoration check. Persistent or ENT-type symptoms, post-nasal drip, mucus, recurrent tonsil stones, schedule ENT. Negative home checks with unusual smell or systemic signs, consult your primary care clinician for metabolic evaluation. No single home test gives a definitive diagnosis. These are screening steps that point toward the right kind of professional help. The primary value of the strategy is that it reduces guesswork, saves unnecessary treatments, and gets you to the right provider faster. A few more practical notes before we finish. If you're using a water flosser, start at a low setting to avoid gagging or gum trauma. If you take blood thinners or have a bleeding disorder, discuss this with your clinician first. Avoid alternating multiple strong self-directed antiseptics, hoping one will do it all. Time-limited, evidence-based trials are safer and more informative. If you notice rapid worsening, new pain, swelling, or systemic signs, seek urgent evaluation. Persistent bad breath alone without systemic signs is rarely an immediate emergency, but be alert to red flags. Real outcomes and timelines. 3 short follow-ups to close the loop. Anna, tongue coating. After 2 days, she saw the biggest drop in breath scores, and by 2 weeks, she'd incorporated gentle scraping and no longer avoided close conversation. She still keeps a small log around times of stress or travel when habits lapse. Marcus, periodontal disease. His 48-hour trial gave limited change, and his floss smell stayed. At the dental visit, he was found to have deep pockets. After scaling and root planing and a reinforced home regimen, his breath scores gradually improved over several months. The key was combining professional care with sustained home hygiene. Leah, ENT pathway. Her pattern of mucus and negative oral checks led to ENT assessment. Nasal endoscopy confirmed chronic rhinosinusitis with post-nasal drip. With saline irrigations, topical steroid therapy, and allergy management, the odor diminished over weeks. Final practical checklist to take away. Do the 3 quick checks: tongue scraping, floss gauze, tonsil visual. Run the 48-hour trial consistently. Extend the structured routine to 2 weeks if necessary, and use concise documentation. If you get clear improvement, maintain the new habit and schedule routine dental care. If improvement is limited, choose referral based on clues: dentist for floss gauze positive, ENT for tonsil sinus clues, PCP for systemic smells or medication issues. Watch for red flags and seek urgent care when systemic or airway signs appear. If you want hands-on technique for the tongue scraper, the gauze floss test, and the salt gargle method, watch the linked hands-on demo where we show step-by-step technique and safe ways to document what you find. If this plan sounds like something you can try, bring the clinician script in the description to your appointment so your dentist, ENT, or primary clinician has a clear, concise summary of what you've done and observed. You're not alone in this, and with a focused, safe approach, you can find the likely source, reduce the stigma, and return to conversation with confidence.